Welcome, LeTu University students, to this lecture today regarding computerized physician order entry, clinical decision data support, and clinical order sets. These are all three major functionalities of a certified EMR or EHR system. Notice we use those terms synonymous with each other. There's never really been a big distinction between EMRs and EHRs, at least only from a textbook perspective. Today, there is no distinction, and we use both terms synonymous because they both can meet national standards for interoperability. And what that is the ability for a provider or a hospital to send your health information electronically to another EMR or EHR system. That system can then consume the record in its original form, original context, and original meaning. And that's what interoperability means in healthcare. Probably doesn't sound that big of a deal because we have interoperability everywhere else in our lives. We have it with banking and finance that we've had for years. You have the ability to transfer funds all over the world with your smartphones, with your bank accounts, with other types of financial vehicles. We can also do it with social media. Those of you that are on Facebook technology and Snapchat, Instagram, that's interoperability. Your ability to communicate a message, a photo, a document, and for it to maintain its original context, form, and meaning to the person that you're sending it to. So then here we are in an environment where we have a huge adoption rate of electronic health records in both hospitals and ambulatory institutions. However, that wasn't enough. They were always mandated to use EHR and EMR technology in a meaningful way. And that's where you get the meaningful use mandates that were rolled out in three phases over the past 10 years or so until we get today to the program of promoting interoperability. So let's talk about some of that meaningful use functionality. The first one would be computerized physician order entry. And what that is the ability of the physician, physician assistant, nurse practitioner, to enter their orders electronically into the EMR system. Probably doesn't seem like a big deal as we sit here in 2019, 2020, 2021, and beyond. But 10 years ago, it was a big deal because a lot of the errors that we saw in healthcare came from medical professionals unable to translate the doctor's orders. And that could have been for a number of reasons. A big reason was handwriting, something as simple as not being able to translate the handwriting. But there were other things like context, that were involved. And so once the electronic health records became viable and meaningful use became a mandate, physicians were then forced to enter orders into the electronic health record. And these orders could have been something like the care plan, the intervention plan, procedures that the physician wanted the medical assistant or the nurses to perform, prescriptions, e-prescribing. Technically, it's outside of computerized physician order entry, but they go hand in hand. And so now we're in an environment where when you see your primary care provider, your specialist, or any attending physician in a hospital, all of the orders that they have for you will now be typed into the system and in a way that it is legible, and the people retrieving the order have the ability to comprehend it and understand it. So now here we are. We've got the doctor with the ability to enter her orders directly into the system. And there's these algorithms working in the background. These algorithms are what we call clinical decision support. Sometimes you'll see the acronym CDSS. And there's two types of decision support. There is a financial decision support that was around for years before the clinical decision support. And so in some environments, they may use those terms synonymous, and you have to make the distinction that indeed we are referring to clinical decision support. So when the doctor gets ready to place his or her orders in the system, these alerts and messages will pop up, informing the physician of certain indicators that were identified by the CDSS algorithm. For example, let's say if the physician is putting orders in the system that you should be on a specific diet, that you should have a specific care plan, and that you should have a specific prescription. Well, when the doctor puts that in the system, if you already have a food allergy or some type of medical history that was pre-recorded in the system, and that physician assigns a Atkins diet, excuse me, for you, well, the clinical decision support message will pop up and say, well, wait a minute, this patient is gluten intolerant. And so that's a clinical decision support message. Now the physician has to make a decision. They have to click on that message and say, I acknowledge that, and we can move forward. Or perhaps now that they understand that the patient is gluten intolerant, they are able to adjust their order in order to satisfy the requirements of the clinical decision support. Medication errors are also medication notifications, or medication inconsistencies are also a huge part of clinical decision support. So if the doctor prescribes you a antibiotic or perhaps some penicillin, and it's already been established in the patient's medical record that they are allergic to penicillin, when the doctor goes to order that, then that will pop up. And the doctor will then have to make a decision. Again, either click on it and acknowledge it and move forward, or move in a different direction by prescribing you another pharmacological intervention that you will not be allergic to. So you can see how computerized physician order entry, that CPOE, and CDSS, they work hand in hand. You've got physicians that are ordering and putting orders in for patients, and you've got this algorithm working in the background that is mining the patient's database, looking for food allergies, drug allergies, and other types of information in the patient's history and in the patient's medical record that could somehow be in conflict with what the physician is ordering. And then finally, that gets us to this whole idea about order sets, or clinical order sets. Clinical order sets are really templates or patterns that physicians use regularly. So if they have patients that present with diabetes, for example, they may have an evidence-based care plan or evidence-based intervention plan that they use for all of these patients. And if indeed that is a fact, that intervention or that care plan can be codified into an order set. So now the patient comes in, the physician performs his assessment on the patient and decides that they want to follow their standard evidence-based plan for intervention. Well, if it's already captured in an order set, then all they would have to do is click on a drop down box and click on that order set. They would have the ability to edit the order set, but some of the components in the order set would be the care plan, would be the prescription, would be any type of referrals, any type of procedures that the physician would normally follow when a diabetic patient presents in her or his office. And so you can think of clinical order sets as a pre-designed template that physicians can use to kind of speed up the process of both clinical documentation and clinical intervention. However, must be caution there, especially when it comes to order sets. Real easy to do something called record cloning. And I know that's kind of beyond the scope of our lecture today, but record cloning is if you see 20 patients or 30 patients in a given day, and you are cloning or copying and pasting the notes, the SOAP notes for each patient, and you're just going in there changing specific aspects of it to meet the patient's criteria. You can already see how loosey-goosey or how much of a gray area that is already. But that's what these templates and the automation does in the EHR system. In one hand, it helps the physician be more efficient and it speeds up the process. But on the other side of the coin, it's a slippery slope. As a matter of fact, a company that I consulted for, our assistant medical director actually got fired for record cloning. And in her situation, she straight copied and pasted SOAP notes from diabetic patients into patient records that weren't diabetic. And so when the people at the corporate office, when they audited the records for Q&A purposes, they saw pretty much exact duplicates of notes across multiple patients. And a lot of these patients didn't even have the conditions that were outlined in the clinical notes. Now, and that example is not unique to the company that I consulted for. As a matter of fact, that was and still is a huge trend in the healthcare space. Payers are starting to push back, like CMS and other private payers, on note cloning. And so now the medical community and physicians are in a transition period where you want to be able to take advantage of the cutting edge and innovative technology that CPOE, CDSS, and clinical order sets provides providers in order to be more efficient, in order to make sure that their evidence-based orders and evidence-based decision making is sound, but at the same time staying away from the traps, staying away from the slippery slopes of duplicating notes, duplicating orders across multiple patients that are not relevant to the specific patient. So that is the synopsis of computerized physician order entry, CPOE, clinical decision support system, CDSS, and clinical order sets. Thank you so much for listening, and God bless you.